Imagine telling your healthiest, most dedicated 62-year-old patient to just rest her knee.
Right.
And in doing so, you accidentally trigger this cascade of tissue degradation, profound clinical depression, and, well, accelerated biological aging.
Which happens all the time, unfortunately.
Exactly. Today, we're examining exactly why the standard orthopedic playbook for the aging athlete is not just outdated, but it's actively harming the very people sitting in your waiting room.
Yeah, it's a massive blind spot.
It really is. So picture a patient sitting in your examination room right now. She's 62 years old. She's been running consistently since her early 30s.
A veteran runner.
Spot on. She completed a marathon last year, highly respectable time, and she's right in the middle of a rigorous training block for her next one. But she presents to your clinic today with 6 weeks of insidious, progressive anterior knee pain.
Okay, very classic presentation.
Right. And when you walk into that room, it is absolutely critical to understand one fundamental truth before you even glance at her chart. She has not come to your clinic to be told to stop running.
Absolutely not. She wants to know how to keep running.
Exactly. For this patient, running isn't just, a cardiovascular protocol. It's not about burning calories. Her mental health, her social life, her community, her entire sense of autonomy is inextricably tied to this sport.
I mean, it's her identity.
Yes. So telling her to just stop running is not neutral clinical advice. To her, you're asking her to abandon her identity, and she has precisely zero intention of doing so.
That is the perfect encapsulation of the clinical stakes we're facing here. When you instruct a patient of this specific archetype to cease their primary physical outlet, you aren't just altering a mechanical lure across a joint.
No, you're doing much more than that.
Right, you're fundamentally disrupting their entire biopsychosocial equilibrium. And the systemic issue we face in orthopedics and sports medicine is that the traditional templates we use, they were just never designed for this demographic.
Not at all.
If you look at the foundational textbooks, the vast majority of our clinical pathways, our rehabilitation protocols, they're all built around young athletes. We are rigorously conditioned to treat the 20-year-old collegiate footballer or the 25-year-old professional track athlete.
And then on the other side of the spectrum, what do we have?
Exactly. We have our geriatric templates. But those are designed around frailty, falls prevention, and very basic activities of daily living.
Which simply doesn't apply to her.
No, this 62-year-old marathoner exists in this massive systemic blind spot right between those two distinct medical disciplines.
And that blind spot is exactly what we are addressing in this deep dive.
Yeah.
Because the demographic landscape of your clinic is shifting rapidly. The aging athlete population is growing exponentially.
We see it every day.
We do. We're seeing this profound increase in individuals in their 50s, 60s, and 70s who are running ultramarathons, climbing mountains, lifting heavy weights. They absolutely refuse to adopt the sedentary lifestyle expected of their parents' generation.
They completely reject that frail geriatric model.
They do. Yet, biologically, we have to admit, they simply don't possess the tissue reserve or the cellular turnover rate of a 25-year-old.
No. The biology is fundamentally different.
So our mission today is to construct a new set of clinical templates for you. Frameworks that take the realities of biological aging seriously whilst simultaneously taking high-level athletic performance seriously.
We really must treat this combination as a highly specialized clinical population. To do that effectively, we have to first establish a rigorous biological reality check.
Right.
Before we even approach diagnostics or treatment plans, we have to understand how the physiological baseline of a 60-year-old high performer differs from that textbook 20-year-old athlete.
Structurally, biomechanically, biochemically, it's all different.
Entirely. We simply cannot apply the same mechanical expectations to tissues that have undergone decades of cellular changes. The assumption that an active older adult is just a slightly slower version of a young adult is a really dangerous clinical fallacy.
It is. I think a good analogy to frame this, and let's actually look at the mechanisms behind it, but it's very much like maintaining a high-mileage classic car, as opposed to a sports car fresh off the production line.
I like that analogy.
Right. Both are unequivocally built for speed. Both can hit remarkable metrics. But the maintenance schedule, the structural tolerances of the chassis, the elasticity of the components, the margin for error is fundamentally different.
You can't apply the aggressive tuning of a new engine to a classic chassis without expecting a catastrophic structural failure.
Spot on. But in the clinic, we often treat sports medicine and geriatrics as these entirely non-overlapping silos. Why does this leave such a dangerous blind spot? What is actually happening in the chassis of our 62-year-old runner?
Well, the blind spot exists because classical training assumes athletic performance and advanced age are mutually exclusive. But to understand the classic car analogy, we have to dive into the tissue characteristics at a really microscopic level.
Okay, let's get granular.
Connective tissues, specifically tendons, ligaments, articular cartilage, they change drastically with age, regardless of the individual's cardiovascular fitness. The tendon of a 60-year-old is structurally, compositionally, and mechanically distinct from a 20-year-old's.
Even if they are subjected to the exact same external training load?
Even then, yes.
Okay, so when you say structurally and compositionally distinct, what exactly are we looking at under the microscope? I know we talk a lot about AGs, advanced glycation end products, but how do they actually alter the mechanical properties?
That is the crucial question. So advanced glycation end products are proteins or lipids that become glycated due to sugar exposure over time.
Over decades, really.
Exactly. Over decades, these AGs accumulate in the extracellular matrix of the tendon. And what they do is form these non-enzymatic crosslinks between the collagen fibrils.
Which normally need to fly past each other, right?
Yes. In a young, healthy tendon, collagen fibrils are aligned in parallel and slide slightly past one another. That's what gives the tendon its elasticity, its ability to absorb kinetic energy and recoil.
But the AGs interfere with that.
They do. When AGs cross-link these fibrils, they literally glue them together.
Wow. So it's like taking a fresh rubber band which stretches beautifully versus a rubber band that's been left out in the sun on a car dashboard for 5 years.
That is spot on.
The sun-baked rubber band loses its compliance. If you stretch it with the same force, instead of expanding, it just becomes brittle and develops micro tears.
That is exactly the mechanism. The tendon becomes stiffer and significantly less compliant. So when our 62-year-old patient goes out for her 20-kilometer weekend-long run, her cardiovascular system is pushing her forward effortlessly.
Because the engine's still great.
Right. But her Achilles and patellar tendons are not absorbing those ground reaction forces with the same viscoelastic efficiency they had 30 years ago.
So instead of stretching.
Instead of stretching, those glued-together collagen fibrils are sustaining micro-ruptures. And furthermore, alongside the stiffening, we see a drastic decrease in cellularity.
You're talking about the tenocytes, the actual cells responsible for maintaining that tendon matrix.
Precisely. In an aging tendon, the total number of tenocytes decreases. And the ones that do remain, they're metabolically sluggish, their synthetic activity just drops.
So not only is the tendon sustaining more microdamage because it's stiff.
Yes, but the biological workforce required to repair that damage has been cut in half, and it's operating at a fraction of its youthful speed.
That's a terrible combination.
It is. We also see a shift in the proteoglycan content. The ratio of dicorin to beta-glycan alters, which reduces the tissue's ability to retain water.
And a dehydrated tendon is a less resilient tendon.
Exactly. It further compounds its inability to manage compressive and tensile loads.
So if the tissue is stiffer, less compliant, dehydrated, and has this diminished cellular workforce,
Yeah.
what does that translate to in practical clinical terms? When she finishes that long run, what's the actual difference in her recovery curve compared to a younger runner?
Well, it translates to a drastically narrowed margin between productive training stress and injury-producing stress.
Right, the window is much smaller.
Exactly. In a younger athlete, the tendon has high hysteresis. It absorbs and dissipates kinetic energy efficiently, and that robust tenocyte population quickly upregulates collagen synthesis to repair microdamage within, say, 48 to 72 hours.
A highly efficient cycle of breakdown and overcompensation.
But in the older athlete, that repair process is profoundly sluggish. The mechanical load creates the microtrauma, but the biological response is delayed and just much less robust.
So an injury that might take a young person 2 weeks to get over.
Might take 3 to 4 months in this cohort. The tissue simply cannot turn over the damaged matrix proteins at the same velocity. You have to recognize that the biological clock of tissue repair runs significantly slower here.
This brings us to a really crucial contextual factor that is chronically overlooked, particularly for female athletes, and that's the endocrine environment.
Oh, absolutely.
Historically, sports medicine has provided deeply under-personalized care for women. We're often just treated as smaller men in the textbooks. But with our 62-year-old marathoner, we are dealing with a postmenopausal biological environment.
Which is a profound physiological shift.
Let's talk about estrogen. We all know estrogen drops post-menopause, and we usually associate that with bone density loss. But we're talking about tendons and ligaments here. How exactly does estrogen withdrawal downregulate the health of a tendon at the receptor level?
The hormonal context is paramount. Ignoring it in your clinical assessment is bordering on negligence, honestly. Estrogen plays a profoundly protective anabolic role in connective tissue homeostasis. It's far beyond just bone
Where
metabolism.
tendons are actively involved.
Yes, estrogen receptors, specifically ER alpha and ER beta, are heavily expressed in the fibroblasts of ligaments and tendons and in the synoviocytes of the joints.
So the tendon itself is actively listening for estrogen.
Exactly. Anastril regulates fibroblast proliferation and directly stimulates collagen synthesis. It provides the signaling pathway that tells your tendon to rebuild itself after the mechanical stress of a run.
And postmenopause.
That precipitous drop in estrogen effectively mutes that signal. You withdraw the anabolic stimulus.
Wow.
This alters the collagen synthesis rates, accelerates that loss of tissue compliance we discussed, and vastly increases the vulnerability to tendinopathy. The tendon is left trying to repair itself without its primary biochemical catalyst.
And obviously, this isn't just a soft tissue issue. The bone architecture is compromised, too.
Yes. The withdrawal of estrogen leads to a rapid phase of bone mineral density loss. Osteoclast activity, the cells that break down bone, starts to outpace osteoblast activity.
Which significantly increases the risk of trabecular microfractures. Right?
Yes, and overt stress fractures in the lower extremities. Plus, the anabolic resistance of aging skeletal muscle is exacerbated by these hormonal shifts, making muscle mass retention significantly more difficult.
Now, it's important to note that male athletes aren't entirely immune to this endocrine shift either, even though the curve is different.
Correct. In older men, we see a parallel, albeit more gradual, decline in free testosterone and insulin-like growth factor 1, or IGF-1.
And that andropausal shift similarly impacts recovery.
Yes, it impacts muscle protein synthesis, recovery velocity, and tendon robusticity. So whether you are treating a male or female aging athlete, you're effectively managing an individual whose internal anabolic drive has been fundamentally downregulated.
Right. So we have this high-performance engine, the cardiovascular system, trying to operate within a chassis that is biologically stiffening, dehydrating, and lacking its previous anabolic hormonal support.
A recipe for complex injuries.
Exactly. But there's another massive variable we need to factor into our assessment: cumulative load. This 62-year-old patient has a 30-year training history.
Which is a massive double-edged sword.
It really is. On one hand, she has assets a 20-year-old simply cannot replicate: a deeply conditioned cardiovascular system, decades of refined movement skills, and immense psychological resilience. She knows how to suffer and push through fatigue.
Those are undeniable assets. The psychological fortitude of a veteran endurance athlete is a powerful tool for rehabilitation.
But the liability side of that ledger is just as heavy.
It is what you are dealing with in the examination room. 3 decades of continuous running results in an immense accumulation of microtrauma. Her orthopedic history is likely highly complex.
She might have had a partial meniscectomy in the 90s, chronic plantar fasciitis on the right, maybe Achilles tendinopathy on the left.
Precisely. Which means when she presents with this new acute anterior knee pain, you are not looking at a blank canvas. You're looking at a highly compensated, intricately balanced biomechanical system. A new acute injury, or even a subtle shift in her kinetic chain, say, slightly reduced dorsiflexion in that previously injured ankle, can trigger a cascade of compensatory failures across joints that have already exhausted their structural reserve.
Her body has spent 30 years finding ways to offload damaged structures.
And eventually, the structures taking up the slack begin to fail.
And compounding that orthopedic complexity is the systemic medical complexity. This is an area where I feel traditional sports medicine fellowships often fall short.
I completely agree.
Active patients in their 60s and 70s aren't immune to systemic aging just because they run. They frequently present with a convergence of comorbidities that a younger athlete would never have: hypertension, type 2 diabetes, cardiovascular disease, osteopenia.
Right.
How does this intersection alter your clinical decision-making when she's sitting in front of you? We can't just focus on the knee joint.
It forces you to be a comprehensive systemic physician, not just a joint mechanic. You must integrate the systemic medical context with the localized sports problem, primarily because of the pharmacological interventions associated with these comorbidities.
The drugs they're taking interact directly with their musculoskeletal health.
Yes.
Let's break that down. Give me a specific, common pharmacological interaction that a clinician might miss if they're only focused on the knee pain.
Let's look at fluoroquinolones. Suppose our runner is mildly hypertensive, and she recently visited her GP for a respiratory tract infection or urinary tract infection. Her GP prescribes a fluoroquinolone antibiotic like ciprofloxacin.
Very common.
Very common. As an orthopedic clinician, you must be acutely aware of the synergistic risk of tendon rupture here. Fluoroquinolones don't just weaken tendons abstractly. They actively upregulate the expression of matrix metalloproteinases, or MMPs.
And those are the enzymes that actively chew up collagen types 1 and 3.
Exactly.
Wow. So you have a patient whose tendon is already stiffened by AGEs, already deprived of estrogen, already suffering from a sluggish tenocyte population. And now, this antibiotic is actively unleashing enzymes that dismantle the collagen matrix from the inside.
It creates a catastrophic structural deficit almost overnight. If you don't ask about her recent medication history, and you clear her to do heavy plyometrics or hill sprints for her knee rehab, she may rupture her Achilles tendon right there during the session.
That is terrifying.
And similarly, if she has borderline type 2 diabetes, the chronic hyperglycemia vastly accelerates the accumulation of those advanced glycation end products we discussed, further degrading tendon compliance.
What about statins? They are incredibly ubiquitous in this age group for managing hyperlipidemia.
Statins are a classic example. Statin-induced myopathy is prevalent. If a patient on statins presents with significant muscle aching and weakness, you must differentiate this pharmacological side effect from training-induced delayed-onset muscle soreness.
Or just an acute muscle strain.
Right. If you misdiagnose statin myopathy as simple overtraining and tell her to just push through it, you risk precipitating rhabdomyolysis. You simply cannot safely prescribe a rehabilitation protocol without fully accounting for how these systemic conditions and their pharmacological treatments compromise her biological capacity to heal.
Right, because the connective tissue is mechanically different, the hormonal environment is altered, and the cumulative history and pharmacology are so complex.
Exactly.
So the way these athletes actually present in your waiting room requires a completely different diagnostic lens. If you are looking for the same clinical patterns you see in university athletes, you'll misdiagnose these patients entirely.
You'll miss the real issue.
Let's translate this biology into specific diagnostic patterns, starting with what is arguably the most ubiquitous presentation: the gradual onset overuse injury. We aren't talking about a sudden traumatic ACL tear from a pivoting tackle on a rugby pitch.
No, we're talking about the slow, insidious ache that creeps up over months.
The insidious onset.
It is the absolute hallmark of the aging athlete. In younger cohorts, you frequently see acute macrotrauma severe sprains, frank joint dislocations. In the older athletic population, the overwhelming majority of presentations are chronic overuse pathologies.
Insertional or mid-substance tendinopathies, bone stress reactions.
Progressive chondral overload, yes.
How does the patient typically describe the progression of this pain?
It is almost always a deeply predictable narrative. They'll often describe a subtle ache that initially only appeared the morning after a particularly long run.
And they probably just ignore it.
Of course they do, because it fades. Then it progresses to pain during the first few kilometers of a run that supposedly warms up and disappears. This gives them false confidence.
Right.
Finally, it escalates to constant, unremitting pain that alters their biomechanical gait and completely inhibits their performance. By the time they actually sit in your clinic, the pathology has been developing for months.
Now, here is where we need to interrogate our standard clinical reflexes. Let me play devil's advocate here for a moment. Standard biological logic dictates that if a tissue is damaged, inflamed, or painful, you offload it to let it heal.
Right.
If I have a runner with acute, agonizing Achilles pain, telling her to continue loading that tissue feels totally counterintuitive. It feels like malpractice. Why does the traditional advice of just rest it for a month completely fall apart here?
Yeah.
Why does offloading backfire so aggressively in this demographic?
I understand the instinct. But prescribing absolute rest for a degenerative tendinopathy in an aging athlete is often the absolute worst intervention you can make.
Really?
Yes. It is a catastrophic misunderstanding of mechanotransduction. Tendons are highly mechanotransductive tissues. This means the cells within them, the tenocytes, rely on applied mechanical load to survive and function.
How does that work?
The physical shear stress of loading is detected by integrins on the cell membrane, which triggers mRNA transcription for collagen synthesis and aligns the extracellular matrix.
So the mechanical load is literally the biological signal telling the cell to stay alive and do its job.
Precisely. If you prescribe complete rest and immobilize that joint, you are entirely removing the primary stimulus for tissue homeostasis. the integrins go silent.
And the cells just power down.
The tenocytes, trying to conserve energy, actively downregulate their synthetic activity. The tendon rapidly undergoes catabolic degradation, losing both cross-sectional area and tensile strength. We term this stress shielding.
So while the patient is resting on the couch, thinking they're doing the right thing and healing, their tendon is actively dismantling itself.
Yes. And here is the clinical disaster. When the patient inevitably attempts to return to running after 4 weeks of complete rest, the tendon is actually significantly weaker, stiffer, and less capable of handling the load than it was before the rest period.
The cardiovascular engine is ready to go, but the structural chassis has degraded.
Exactly. This leads to an immediate and often much more severe recurrence of symptoms within the first week back. This is exactly why structured progressive load management is the superior evidence-based approach.
You're talking about heavy, slow resistance training or isometric loading protocols.
Exactly. You must load the tissue to heal the tissue. You use heavy, slow resistance to provide a massive mechanotransductive signal to the tenocytes without subjecting the brittle tendon to the high-velocity kinetic impact forces of running.
But the dosage has to be right.
The dosage must be exquisitely calibrated to their current biological capacity, but you absolutely cannot prescribe inactivity.
Let's look at a second. Immensely frustrating clinical trap, which ties directly into this, the imaging dilemma.
Oh, this is a big one.
Our patient has had 6 weeks of knee pain. She is deeply anxious about her upcoming marathon, and she is adamantly demanding an MRI to see what is torn. Or, conversely, the clinician, pressed for time, orders the MRI as a default reflex before truly examining the patient.
Which happens far too often.
The scan comes back, and suddenly the clinician starts treating the pixels on the screen instead of the human in the room. What is the specific danger here in an older athletic cohort?
This is where we end up doing real, tangible iatrogenic harm. We cause harm through overtreatment. In the aging population, imaging abnormalities are ubiquitous and, crucially, largely asymptomatic.
Right.
If you take 100 pain-free, active 60-year-old runners off the street and put their knees in an MRI scanner, you will find degenerative meniscal tears, significant chondral defects, and osteophyte formations, a staggering percentage of them.
Even in the shoulders, right?
Absolutely. If you ultrasound their completely asymptomatic shoulders, you will find rotator cuff tendinosis and partial or even full-thickness supraspinatus tears.
These are basically the internal wrinkles of the musculoskeletal system. They are age-appropriate, normal structural changes.
Exactly. They are the graying hair of the meniscus. The clinical trap is the cognitive bias of attributing the patient's current acute pain to a chronic, asymptomatic structural finding simply because it is brilliantly illuminated on a high-resolution MRI.
I call this the victim of modern imaging technology scenario. Let's apply this to our marathoner. Say she has developed anterior knee pain from an acute patellar tendinopathy brought on because she suddenly increased her hill repeats.
Okay.
But we run the MRI, and it reveals a horizontal cleavage tear of the medial meniscus. The trap is fixating on the meniscus and ignoring the tendon.
And the fixation leads to disastrous interventions. If that meniscal tear has no mechanical symptoms, meaning there is no true locking, no catching, no joint effusion, and no genuine giving way, it is highly likely to be a completely incidental finding that has been there for a decade.
Right.
If the clinician fixates on the meniscal tear and recommends an arthroscopic partial meniscectomy to clean it up, they are subjecting the patient to an entirely unnecessary surgical intervention.
And that surgery will not cure her patellar tendon pain.
Not only will it not cure the tendon pain, but removing that meniscal tissue alters the contact mechanics of the knee, vastly accelerating her progression to symptomatic osteoarthritis.
Plus, the surgical recovery derails her training completely.
It precipitates the systemic detraining and stress shielding we just discussed. The expert clinician understands that in the aging athlete, the correlation between structural imaging findings and the actual nociceptive source of pain is incredibly weak.
Your clinical examination and history must always supersede the radiology report.
Always. You must treat the functional deficit, not the incidental degenerative change.
That leads perfectly into a third diagnostic pattern, which is heavily driven by the unique psychology of this demographic, the overtraining paradox. Let's look at the mindset.
It's a fascinating mindset.
Our veteran runner starts feeling herself getting a little slower. Her recovery takes a day longer than it used to. She feels the loss of that youthful physical buoyancy. Instead of recognizing this as a normal biological signal to optimize her recovery protocols, she panics.
She thinks she's losing her edge.
Exactly. She interprets this slowing down as a loss of fitness. And to combat it, she adds more miles, increases her weekly volume, and pushes her intensity to try and forcibly hold on to her past performance metrics. And this triggers a catastrophic cascade.
It is a tragically common self-destructive cycle. It is driven by the athlete's psychological refusal to accept their shifting physiological baseline. When they feel their performance slipping, their decades of conditioning dictate that the solution is always to work harder.
They believe they can outwork biological aging.
Yes. However, because their connective tissue tolerance is already reduced and their endocrine recovery systems are blunted, this sudden spike in workload vastly exceeds their biological capacity to adapt.
What is happening systemically when they push past that capacity?
They enter a state of systemic overreaching, which quickly transitions into overtraining syndrome. Their hypothalamic pituitary adrenal axis is constantly stimulated. Cortisol levels remain chronically elevated.
And chronic cortisol is profoundly catabolic.
Exactly. It further suppresses the already diminished anabolic response, inhibiting protein synthesis and increasing tissue catabolism. They are breaking down tissue faster than they can rebuild it.
Which leads to those multiple shifting injuries.
Yes. You'll see a patient present with a proximal hamstring tendinopathy combined with a tibial bone stress reaction and perhaps immune suppression leading to recurrent upper respiratory tract infections. The entire system is failing under the load.
How do you identify this pattern early, before the tissue completely fails and fractures? When she's sitting in your clinic, what are the specific clinical signs or historical clues you are looking for?
You cannot rely on a standard orthopedic physical exam to diagnose overtraining. You have to act as a detective and ask highly specific questions about her training metrics and her subjective systemic well-being.
Like beyond just, how much are you running?
Oh, that is entirely insufficient. You need to ask, how is your sleep quality? Are you waking up unrefreshed? Has your morning resting heart rate elevated by 5 or 10 beats per minute? Are you experiencing unexplained fatigue during basic activities of daily living, like walking up the stairs at work?
You're checking her mood as well.
Has your mood altered? Are you feeling unusually irritable or unmotivated? You're looking for the systemic physiological markers of distress.
And looking for a history of recurrent, shifting low-grade injuries.
Exactly. If she tells you she had Achilles pain 2 months ago, plantar fascia pain last month, and now she has knee pain, and her response to all of this has been to maintain or increase her training volume to push through it, you are looking squarely at the overtraining paradox.
The intervention there requires immense psychological tact, doesn't it? You can't just tell her to stop.
No, you have to strategically reframe recovery. You must position recovery not as weakness or giving in to age, but as an active, scientifically crucial component of high performance. You have to convince her that sleeping and resting are training modalities.
But what if we don't catch it in time? What happens when this overtraining paradox actually results in a blown tendon or a severe stress fracture, and she is genuinely forced onto the couch for 3 months?
That's when things get really difficult.
The tissue changes we talked about earlier, how fast do they accelerate when the mechanical load drops to 0? This brings us to the fourth pattern, the deeply frustrating return after a mandatory break. Let's say she's finally cleared to return. In her mind, she is still the athlete she was 3 months ago.
She still has the identity of a 3-hour marathoner.
Exactly. But the tissues do not bounce back with the elasticity that they once did. The detraining effect in this cohort is rapid, and the rebuilding phase is painfully slow.
The physiological reality of detraining in the older adult is severe, and it is vital that the clinician anticipates it. We have to discuss sarcopenia, the age-related loss of skeletal muscle mass, strength, and function.
Which is usually a slow process.
It is in the general aging population,
Yeah.
but it is accelerated dramatically during periods of immobilization or enforced inactivity in athletes.
It's a use-it-or-lose-it scenario on overdrive.
Precisely. A 20-year-old might lose a small percentage of muscle cross-sectional area after a month of rest in a boot, and their robust neuromuscular system will allow them to rebuild it in a few weeks once the boot comes off. Our 62-year-old will lose significantly more muscle mass in that same time frame.
And the neuromuscular efficiency degrades rapidly, too.
Yes, the central nervous system's ability to recruit those remaining muscle fibers quickly and powerfully just drops.
So what happens on that first day she tries to run again?
This is where the mismatch occurs. When she attempts her first run back, her cardiovascular system, which retains adaptations much longer than skeletal muscle, might feel surprisingly fine. She has the engine to run 5 kilometers comfortably. She doesn't feel out of breath.
But her musculoskeletal chassis.
The sarcopenic, atrophied muscles and the stress-shielded catabolized tendons, they cannot handle the impact forces. The engine overpowers the chassis, leading to an immediate secondary injury.
So the clinician's role here has to shift from pure diagnostician to expectation manager. How do you manage that immense psychological frustration when she takes those first strides and realizes her body is failing her at a pace she used to consider an easy warm-up?
You must preempt the frustration by setting explicit, biologically grounded expectations before she takes a single step out the door. You sit her down and explain the physiology of sarcopenia and tendon detraining clearly. You tell her, your heart is ready, but your tendons have been asleep.
And you provide a highly structured return-to-run program,
Often a very conservative walk-run interval progression.
which she will inevitably think is beneath her.
She will absolutely think it is beneath her. The cardiovascular effort will feel absurdly easy to her. But you must explain that the specific, low-level mechanical dosage is precisely what is required to stimulate tendon and muscle synthesis without causing structural failure.
You have to validate that frustration.
You must actively validate it, acknowledging that it feels incredibly unfair, while simultaneously enforcing the unyielding biological reality that tissue adaptation cannot be rushed by sheer willpower. In this phase, your primary clinical role is to protect the patient from her own cardiovascular endurance.
Let's touch on the final and arguably most dangerous diagnostic pattern: hidden fragility.
This is a scary one.
It is. This is the patient who possesses such immense mental resilience and pain tolerance that they continuously push through red flag symptoms that would immediately halt a younger, less conditioned person. We are talking about ignoring the deep, unremitting night pain of an impending femoral neck stress fracture.
Or dismissing the exertional chest tightness of an untreated cardiovascular issue as just training fatigue.
Exactly. When you identify this level of dangerous stoicism, how do you firmly establish absolute medical limits without utterly destroying the patient's identity and discouraging their active lifestyle entirely?
This requires genuine clinical courage. You are dealing with an athlete whose primary psychological coping mechanism for all physical discomfort is to compartmentalize it, put their head down, and push forward. They have spent 30 years learning to ignore pain.
So subtlety isn't going to work.
Not at all. When you identify a true red flag symptom, such as the exquisite fulcrum pain of a high-risk tension-sided stress fracture, or signs of systemic cardiovascular distress like uncharacteristic dyspnoea, you cannot be subtle. You must shift immediately from a collaborative coaching tone to a definitive, unyielding medical directive.
You have to shock them out of their athlete mindset.
Yes. You explicitly name the catastrophic risk. You do not hedge. You say, the type of deep groin pain you are describing is not a tight hip flexor. It is a structural failure in the neck of your femur. If you attempt to run on this bone, it will snap.
Oh, very direct.
You will require an emergency total hip replacement, and your competitive running career will genuinely and permanently be over.
You use the ultimate threat to their athletic identity to enforce the immediate short-term restriction.
Exactly. You leverage their love for the sport to save them from destroying their ability to do it. You name the absolute limit firmly, but, and this is critical, you immediately pivot to what they can do to maintain their cardiovascular fitness and their sanity.
Like deep water running.
Yes. Deep water running, stationary cycling, aggressive upper body ergometer work. You ensure they deeply understand that the restriction is a temporary necessary strategy to save their long-term sport, not a permanent sentence to the couch.
That pivot is the perfect segue into our next core segment, the master clinical skill. Let's say you have successfully navigated these diagnostic pitfalls. You haven't been distracted by incidental MRI findings. You understand the physiological deficits and the pharmacology.
Right.
Now, how do you actually prescribe a treatment plan that this stubborn, highly driven patient will actually adhere to? This brings us to the core philosophy of treating the aging athlete, the profound dichotomy of adjustment versus abandonment.
The absolute bedrock of successful management in this cohort.
Let's define the stakes here clearly. Abandonment is the traditional paternalistic medical advice. It sounds like this. Well, Mrs. Smith, your knee is showing significant signs of wear and tear. You're 62. You've had a good run, but you need to stop running, stop lifting heavy weights, and take up swimming from now on.
A terrible approach.
When you say that, you are demanding that the core activity ends. The patient hears this as a profound loss, what psychologists might term a small death. It is the death of their community, their primary stress relief mechanism, and their self-image.
They will completely ignore your advice.
They will smile politely, walk out the door, throw your prescription in the bin, and keep running. Adjustment, on the other hand, is prescribing fewer miles, changing the intensity distribution, adding mandatory cross-training, or modifying their biomechanical technique. The core activity, the identity, is kept alive.
If you don't grasp this, you cannot treat these patients effectively. The analogy of a musician you mentioned earlier is exceptionally apt here.
Yes, exactly. If you're treating a lifelong concert pianist who has developed osteoarthritis in their hands, adjustment is asking them to play a slightly different arrangement. You ask them to change the tempo or to select a specific repertoire that reduces repetitive loading on the joints.
Right.
Abandonment is telling them to shut the piano lid, lock it, and never touch the instrument again. One approach keeps the artist alive and functional. The other destroys their spirit.
And biologically, abandonment is rarely medically justified unless there is imminent catastrophic structural risk. Most musculoskeletal pathologies in this age group, your degenerative tendinopathies, mild to moderate unicompartmental osteoarthritis, they respond exceptionally well to strategic load modification.
The entire clinical objective is to find that sweet spot of mechanical loading.
Exactly. A load that allows the tissue to adapt and heal without exacerbating the underlying pathology. If you lazily demand abandonment, you not only completely lose patient compliance, but you actively precipitate the massive systemic detraining effects in sarcopenia we discussed earlier. You make them weaker.
So let's break down a highly specific, actionable communication framework for the clinical consultation. How do you physically negotiate this adjustment in the room with the patient? Walk us through the exact steps you take.
It must be positioned as a collaborative negotiation, not a dictation. You are a consultant to their performance. Step one is the most crucial, and it is where many clinicians fail. You must ask for specific, granular numbers.
No vague questions.
None. You don't ask, are you running a lot? That means nothing. You ask, what exactly does your current training architecture look like right now? How many days a week are you running? What is the total weekly mileage? How much of that volume is at a threshold heart rate versus a conversational zone 2 pace?
Because if you don't know the exact mechanical load that's causing the tissue failure, you can't possibly prescribe the correct adjustment. It's like prescribing a drug without knowing the current dosage.
Precisely. Once you have the specific numbers, you move to step 2. You propose a modification to the training architecture, never to the sport itself.
Let's use an example.
Right. If the patient tells you they are running 6 days a week, accumulating 60 kilometers, doing a high-intensity track session on Tuesdays, and doing 0 strength training, you do not say you need to stop running to heal this patellar tendon.
Instead, you frame it as a performance optimization strategy.
Yes. You say, given the biological changes we discuss in this tendon, the stiffness and the slower recovery running 6 days a week is currently exceeding its metabolic recovery capacity. What if, for the next 4 weeks, we adjust the architecture?
So keeping the core, but changing the frame.
Exactly. I want you to run 4 days a week instead of 6. We will maintain your precious Sunday long run, but we will replace the Tuesday track session and one easy run with targeted heavy resistance work for your posterior chain. This will vastly increase the tendon's load capacity so you can run faster without pain.
That is brilliant.
Yeah.
And the clinical rationale underlying that advice is exactly the same as prescribing relative rest. You're fundamentally reducing the repetitive impact load to allow tissue healing.
But the way the patient receives the information is radically different.
They hear a performance solution, not a ban.
By framing it as a strategic, scientific adjustment, you are speaking their language. You're partnering with them to solve a performance problem, rather than acting as a paternalistic, authoritative figure trying to confiscate their sport. The adherence rates are astronomically higher.
But there is a massive prerequisite here, isn't there? To negotiate these adjustments effectively, to talk confidently about threshold paces, zone 2 training, macro cycles, periodization, the clinician actually has to understand the mechanics, the culture, and the vocabulary of the sport.
You absolutely cannot fake it.
You can't fake it in front of a veteran marathoner.
These athletes are highly educated about their sport. If you suggest to a marathoner that they just jog a bit less, or if you confuse a tempo run with a recovery jog, you instantly lose all clinical credibility.
Right.
You must understand the difference between anaerobic threshold intervals and aerobic base building. You must understand how cycling wattage or swimming stroke mechanics impact different joint reaction forces.
This knowledge isn't innate, and it's rarely taught in standard orthopedic residencies.
No, but it is a highly learnable professional asset. The clinicians who are truly exceptional in this field distinguish themselves by immersing themselves in the sports their patients love. They read the training literature, they speak the vernacular fluently. When a patient feels that you truly understand the intense physical demands of their sport, the therapeutic alliance is instantly solidified.
They'll trust your clinical adjustments because they know you fundamentally respect their athletic goals.
Exactly.
This brings us to a crucial juncture, our fourth segment, the hard conversations. Adjustment is the clinical ideal. But as a clinician, you can't rely entirely on a best-case scenario. We have to address the reality of what happens when biological reality imposes an absolute non-negotiable hard limit.
When adjustment is no longer an option.
All right, let's start with scenario one. Genuinely unsafe activity. We touched on this briefly with the stress fracture, but what do you do in those incredibly serious instances where you identify severe cardiovascular red flags or late-stage bone-on-bone structural damage with massive joint instability, where continuing presents a catastrophic risk to life or limb?
The high-functioning patient will inevitably push back.
They'll bargain with you, they'll demand injections to mask the pain. How do you construct a framework for delivering unhedged, direct communication and holding your clinical ground?
In these scenarios, your role shifts entirely from a collaborative coach to a definitive medical protector. Let's take an acutely worsening aortic root dilation identified on screening, or a severely degenerative, unstable varus knee where further high-impact running will inevitably result in a complex periarticular fracture.
Right.
When you deliver this news, you must deliberately strip away all clinical hedging. You do not use soft phrases like, it might be a good idea to consider slowing down. You use definitive, declarative medical language.
Stating the pathology explicitly.
Yes. Your aortic root has dilated to a critical dimension. You state the precise mechanism of catastrophic failure. If you continue to perform heavy, high-intensity interval training, the acute spike in systolic blood pressure significantly increases the mechanical risk of an aortic dissection, which is a frequently fatal event.
And then you brace for the impact because they will fight you.
They will. When they ask for a workaround, when they ask for a beta blocker to just let them race one last time, you calmly and firmly hold the boundary. You say, I understand how devastating this is to hear, but as your physician, I cannot and will not endorse any activity that places your life or limb at imminent risk. There is no training adjustment, no injection, and no medication that makes this structurally safe.
You have to sit in the heavy discomfort of their anger and their profound grief.
Without retreating an inch from your medical diagnosis.
That is incredibly difficult, but absolutely essential. Now let's consider scenario two, which is ethically far more complex. The stubborn patient. This is the patient who doesn't have an immediately life-threatening condition, but who has a severe degenerative pathology, say, advanced hip osteoarthritis, with significant subchondral cysts and pain. You've offered every possible training modification. You've explained that continuing to run 40 miles a week is rapidly accelerating the joint destruction.
But they refuse to stop.
They look you dead in the eye, flat out refuse to slow down, and actively seek your clinical approval or an endless series of intra-articular corticosteroid injections just to keep running. What is the protocol here?
First, you categorically refuse to be an enabler. You do not provide treatments that serve only to mask the nociceptive signal purely to allow them to continue a mechanically destructive behavior. Doing so violates the fundamental medical principle of non-maleficence. You're actively facilitating harm.
So no endless steroid injections.
Absolutely not. Second, you must clearly, dispassionately, and repeatedly state the long-term biological consequences of their specific choice. You say, if you choose to continue to run on this hip, you are actively accelerating the destruction of the remaining articular cartilage. This will likely lead to a more technically difficult joint replacement surgery, higher risks of complication, and a permanently compromised long-term functional outcome.
And you document that conversation meticulously, every word.
Meticulously. You document in the chart that the severe risks were explicitly explained, that the patient demonstrated understanding, and that they have actively chosen to proceed against medical advice.
But crucially, you do not abandon the patient.
This is where many clinicians fail and become defensive. You do not say, well, if you won't listen to me, go find another doctor. You maintain the therapeutic alliance. You tell them, I strongly disagree with your decision. I believe it is harmful. However, I am still your physician. I will continue to manage your overall care. I will monitor the joint deterioration with you. And when you are finally ready to consider surgical intervention, my door is always open to you without judgment.
That is profound distinction, allowing autonomy without enabling destruction.
It requires a lot of professional maturity.
It does.
Yeah.
And it leads perfectly into scenario 3, which is the deepest psychological layer we face, the identity crisis. We're talking about the patient whose entire sense of self, their entire psychological scaffolding, is supported by a single sport.
If they're not a runner, they don't know who they are.
Exactly. If you see this rigid, singular identity foreclosure in a 55-year-old athlete who is just beginning to show early signs of significant joint degeneration, why is it critical that you initiate a quiet conversation early on, long before a structural crisis forces a catastrophic cessation?
Because if that sport is removed suddenly by a catastrophic injury and it's their sole pillar of identity, the resulting psychological collapse is genuinely devastating. We see profound clinical depression, severe social isolation, loss of purpose, and a rapid decline in overall systemic health.
So how does an exceptional clinician handle that?
You recognize this brittle psychological structure early. The quiet conversation is not a single heavy intervention. It's an ongoing, subtle process introduced systematically during routine consultations over years. You do not threaten their primary sport, but you actively explore and encourage secondary physical outlets.
So you're not telling them to prepare to quit. You're helping them build resilience. How do you practically facilitate that in a standard 10-minute consultation? What are the actual words?
You inquire about other interests under the guise of performance enhancement. You might say, your running is going exceptionally well right now. To protect those gains and give your joints some varied mechanical loading to prevent overuse, have you considered incorporating a day of road cycling or swimming into your routine?
You're clinically framing it as cross-training.
But psychologically, you are helping them widen their base. You are slowly introducing them to other athletic communities, other modalities of movement. The ultimate goal is to ensure that when the inevitable day of severe adjustment or outright abandonment arrives, and biologically, if they live long enough, it absolutely will, the sport is not the only pillar holding their mental health together.
You are subtly constructing a psychological safety net over years of consultations. That is incredibly powerful. You're treating the complex biopsychosocial architecture of the human being sitting in front of you, not just the cross-linked collagen fibers in their knee. Let's synthesize the approach we've constructed today. The core thesis of this deep dive is clear. The modern musculoskeletal clinician must treat the whole aging athlete. You cannot compartmentalize the pathology.
No.
You must treat the aging, stiffer, slower connective tissue. You must account for the immense 40-year cumulative training history and the intricate biomechanical compensations. You must deeply understand how shifting postmenopausal or andropausal hormones dictate tissue recovery at the cellular level.
And you must integrate their complex systemic comorbidities.
Right. Understanding exactly how hypertension medications or statins alter their musculoskeletal resilience. And above all, you must recognize and honor the profound identity stakes involved in their sport. You must aggressively pivot your communication away from the lazy, paternalistic dictate of abandonment and master the nuanced, collaborative art of adjustment.
The clinical templates of the past focus solely on the acute macrotrauma of the young collegiate athlete are entirely obsolete for this growing demographic. By embracing the complexity of the aging athlete, you elevate your practice from basic orthopedic joint mechanics to true, comprehensive, modern sports medicine.
As we conclude, I want to leave you with a final provocative reflection to mull over in your clinic tomorrow morning. The 65-year-old marathoner sitting in your examination room today can absolutely still be on the starting line at age 75.
They certainly can.
But they will only get there if the clinical care they receive from you in the intervening decade actively enables it. Are the diagnostic templates, the pharmacological awareness, and the communication strategies you are currently using in your practice building a sustainable biological bridge to 75? Or are you inadvertently treating older athletes like they have a strict, predetermined expiration date?
A vital question for all of us.
If you found today's comprehensive discussion valuable for your clinical practice, please take a moment to rate and share Deep Dive Ortho with your colleagues. Thank you for joining us in examining the profound complexities of the aging athlete. We look forward to seeing you on our next deep dive into the evolving world of musculoskeletal care.